So, good afternoon, everyone. Uh, Department of Medicine, Unit 3 is going to present a clinical combined round today, and we are going to present case obvious but mysterious. It's an interesting case, and we are following up this case from August 2021, and last follow up was done in Jan 20, 2022. So, we have team of doctors here who are going to present this case. I'll invite first to Karan. Please come.
Good afternoon, respected faculties and my dear colleagues. Today I am presenting the interesting case that was present to us in July 2021. The patient is a 51-year-old male businessman, resident of Gurgaon, Haryana, presented to us in the month of July with the chief complaints of fever for 2 months and yellowish discoloration of eyes for 1.5 months. Fever was continuous. It was initially low grade, then gradually rose to 102 degree Fahrenheit on presentation. It was associated with chills without rigors. There was no diurnal variation, and it was relieved by antipyretics. It was associated with yellowish discoloration of eyes for 1.5 months, which was gradually progressive and was associated with dark color urine. There was no history of nausea, vomiting, pain, abdomen, pruritus, or pale color stools. These were associated with decreased appetite, and there was a history of weight loss of around 3 kg over 2 months. There was no history suggestive of any cardiovascular, respiratory, or central nervous system involvement. There was no history of photosensitivity rash or any other rheumatological symptoms. There was no past or family history of TB. There was no past history of blood transfusion. No history of animal bite or pets in the family. Patient was evaluated in the outside hospital from May 2021 and has received the course of antibiotics during this time with no symptomatic improvement. The patient suffered from mild COVID-19 infection in May 2020 and was recovered fully with no residual symptoms. Patient is a known case of type 2 diabetes mellitus since 2016, which is well controlled on oral hypoglycemic agents. Patient has normal sleep pattern, normal bowel bladder habits. There is no history of illicit or over-the-counter drug abuse. There is no history of alcohol intake or chewing tobacco. So summarizing symptoms till now, we have a case of fever for 2 months with jaundice for 1.5 months with associated with weight loss and anorexia. On physical examination, patient was febrile with tachycardia. Teres was present and there was no pallor, clubbing, cyanosis, lymphadenopathy or pedal edema at presentation. Uh, there was no focal signs or was suggestive of any focal or system involvement. There was no skin rash or erythema nodosum. Oral cavity examination was normal. There was no feature suggestive of splinter, hemorrhage, Janeway's lesions or osseous nodes. In eye examination was normal and there was no uveitis and fundus examination was also normal. On systemic examination, liver was palpable up to 2 cm below the right subcostal margin and spleen was not palpable. Chest, respiratory, cardiovascular and central nervous examination was unremarkable and normal. So summarizing history and physical examination, we have a case of fever with progressive jaundice with weight loss, anorexia and hepatomegaly. So thinking on the line of this, the various causes of fever with hepatomegaly can be fall into infectious, infiltrative and inflammatory. Among infectious causes, our top differentials were tuberculosis and histoplasmosis. Among inflammatory, we thought of malignancy like lymphoma, and among inflammatory disorders, the autoimmune hepatitis were our first differential. So patient was evaluated during these 2 months outside, which showed mild increased total bilirubin, that is 1.7, with direct fraction of 1.1, along with raised ALP, that is 543, and raised inflammatory markers like CRP and ferritin. A Monto test done outside showed 8 mm in duration, and other investigation done for common infectious disease were negative and didn't yield any diagnosis. These are the various radiological investigation done for the patient during this time. Ultrasound abdomen, HRCT chest were done in May, and CCT chest abdomen and was done in June, and PET scan was done 20 days before coming on 3rd July 2021. Now I would like to invite Dr. Palak to throw some light on the CT scan images of the patients.
Good afternoon, everyone. I am Dr. Palagat, Senior Resident from the Department of Radio Diagnosis. I'll be presenting the outside CT scan of the patient done on 3rd of June 2021. In these axial contrast images, we can see there is no focal lesion seen within the liver or the spleen, and there are no significant lymphadenopathy seen in the porta hepatis or in the retroperitoneum. Coming to the coronal reformats, there is no appreciable hepatomegaly or splenomegaly in the given sections and as calculated by the scale given, and there were no significant lymph nodes or any other lesion. In the axial contrast enhanced chest scans and the mediastinal window, we can see there is no significant mediastinal lymphadenopathy and the vessels appear normal. And in the coming to the lung window, we can see there are no perilymphatic or central lobular nodules or no consolidation. So concluding, the CCT chest scan done outside on 3rd of June was normal.
Thank you, ma'am. Now I would like to call upon stage Dr. Sneha to interpret the PET scan images of the patient done on 3rd July.
Good afternoon, everyone. Here we can see the PET scan images of this patient done outside in July 2021. On the top left corner grid, we can see the maximum intensity projection image. On the right hand side, in both up and the down lower grid, we can see the fused PET CT image, and the left side bottom grid, we can see the axial CT image of the patient. In the maximum intensity projection image, we can see no abnormal focus of FDG uptake in the study. And in the fused PET CT images, we can see no abnormal FDG uptake in the liver, spleen, or the retroperitoneum. Uh, and the CT image also is normal. So our final impression was that there's no evidence of any abnormal metabolic activity to suggest any infective, inflammatory, or malignant pathology in the study.
Thank you, ma'am. Now, on the basis of history, physical examination, and the investigation, uh, till now, we have a case of fever with progressive jaundice, with weight loss, hepatomegaly, with raised liver enzyme, the ALP more than AST and ALT, and raised inflammatory markers. CCT, chest, abdomen, and FDG PET were non-contributory. So, on the basis of this, we thought of granulomatous hepatitis as the cause of this illness. And various causes for granulomatous hepatitis can be divided into infectious, inflammatory, neoplastic, and drugs. Among these, our top differentials were extrapulmonary tuberculosis, chronic hepatitis, autoimmune associated or EBV, leishmaniasis, histoplasmosis, lymphoma, or sarcoidosis. So, patient was evaluated after admission in our AIIMS, which showed the total bilirubin to be 6.7 with direct fraction of 5.2, along with markedly raised ALP, that is 1268, and raised inflammatory markers like LDH, ferritin, and GGT was also raised at the time of presentation. We did 24-hour urinary calcium, which was raised in the patient, and other investigations were unremarkable. The other finding which is shown in the patient is raised age level, which were elevated, that is 143 units per liter. So, after ruling out the various causes by appropriate investigations, our top three differentials were extrapulmonary tuberculosis, sarcoidosis, and lymphoma. So, to rule out among these, the decision to do percutaneous liver biopsy was taken, and patient had undergone percutaneous liver biopsy during the hospital course. I would like to invite Dr. Rohan from pathology to discuss the slides.
So this was a multiple course of liver biopsy which we received. So here we can see that there is a mild lobular disarray. That means that the portal tract are not dispersed in regular intervals in these. So here we can see that there are no regular portal tracks in these cores. So coming to the high power, we can see a portal tract, portal area here, which shows moderate inflammatory infiltrate, which is composed of lymphocytes, histiocytes, and few polymorphs also. This is another portal area. Along with here also we can see the inflammatory infiltrate, along with focal interface hepatitis also in this area. The limiting plate, which first plate of hepatocytes, and there is inflammation which is spilling into them. This is another portal area. Here also we can see the inflammation. Along with that, we can see a few epithelioid cells here like these. So this is forming a non-necrotizing epithelioid cell granuloma here. However, we can see that the bile duct, which is here, is uninjured. Coming to the hepatic parenchyma also, we can see this granuloma formation here, which is well circumscribed, and there is no necrosis in this granuloma also. High power for the granuloma. There are these classical slipper-shaped epithelioid cells which constitute the granuloma. Again, here we can see that there is no necrosis associated with this granuloma. There are no organisms in it. This is a section from zone 3 of the hepatocytes. So here we can see that there is macrovesicular steatosis here, along with inflammation, which is in between the lobules and all. And here also there is inflammation together along with this nuclear glycogenization, as we can see in these foci. This together constitutes, and along with this, there is cholestasis, intracytoplasmic, and also intraductal cholestasis are there. So together, these findings constitute steatohepatitis. Again, nuclear glycogenization here, and also cholestasis present here, along with the macrovesicular steatosis. Mason's trichrome stain shows fibrosis in the periportal areas and also in the zone 3 areas around the central vein. Here you can again see the macrovesicular steatosis. So to sum up all the findings, there is chronic hepatitis and multiple portal and lobular non-necrotizing granulomas were seen. Steatohepatitis with nuclear glycogenation was noted. There is hepatocellular as well as canalicular cholestasis and fibrosis in portal and zone 3 areas. However, there was no bridging fibrosis or nodule formation as we could see. There is no bridging happening. There are individual parts of fibrosis around the portal area and also in the zone 3. And also we could not demonstrate any acid fast bacilli or any fungi. So diagnosis of granulomatous hepatitis with steatohepatitis with main etiologies being tuberculosis or sarcoidosis was suggested on this biopsy.
Thank you, sir. So on the basis of history examination, the investigation and histopathology of the liver of the patient, our final differential was granulomatous hepatitis with anemia of chronic disease, etiology sarcoidosis, isolated hepatic involvement. So on the basis of this diagnosis, the patient was started on steroid the hospital on 8th August 2021 with TAP prednisolone 30 mg. Patient is being afebrile since August 2021. These are the various follow-up investigation done after starting steroid. The total bilirubin decreased to 1.12 in August and it became in normal physiological limit in November. ALP also decreased from 1268 to 99 November. Thank you. Now I would like to invite Dr. Taruna to discuss the review of literature on the topic.
Good afternoon, respected faculties and my dear colleagues. I will discuss the case that Karan has discussed in two major headings. First is sarcoidosis causing in itself a fever of unknown origin, and second is liver involvement in sarcoidosis. But before I start, I will like to introduce you to FUO. So what is fever of unknown origin? It is defined as a temperature of more than equal to 38.3 degrees Celsius on at least two occasions, with a duration of illness more than equal to 3 weeks in a non-immunocompromised patient who has undergone the following set of investigations as mentioned here. How do we approach a case of fever of unknown origin? After history and physical examination when the patient has underwent the following set of investigations, we look for potential diagnostic clues. If we get the diagnostic clues, we go for a guided diagnostic test, which is non-invasive, followed by an invasive. If, however, the diagnostic clues are absent, we go for whole body imaging, that is PET scan. Now, sarcoidosis in itself causing FEO is not a very common entity. When we look for the etiologies of fever of unknown origin, we see that it is basically categorized into 4 categories. First one being infection, followed by malignancy, connective tissue disorder, and the fourth one being miscellaneous. In connective tissue disorders, we see SLE is the common one, and sarcoidosis is just an uncommon etiology. This is a publication, a review article by William et al. Here we see frequencies of diagnosis within the 4 major categories of classic fever of unknown origin and conclude that infections constitute to form the major chunk of patients who present with FEO. Infections, most commonly tuberculosis, followed by neoplastic, followed by inflammatory were the etiologies of FEO, and in inflammatory also SLE was the common one. Sarcoidosis was just an uncommon etiology of FEO. And even in cases if sarcoidosis will present as FEO, these are the 3 conditions in which sarcoid will present as FEO. The first one being uveo-parotid involvement, the second one where there is massive involvement of the liver by sarcoid granulomas, and the third one being neurosarcoidosis. It is said that excluding the above 3 conditions, fever in a patient with sarcoidosis should suggest an alternative diagnosis. In our patient, we did not have massive involvement of the liver as PET scan was normal. So our patient mounting fever just because of sarcoidosis was in itself a rare entity. Going to the paper which was published by our department in 2012, here 164 patients were studied for the 54 rare manifestations of sarcoidosis, and only 1 out of 164 patients, that is 0.6% of the patient, had presented as PUO. So now we have seen what is FEO. We have seen that sarcoidosis in liver presenting as FEO is not common. Now we will look towards isolated liver involvement in sarcoidosis. That is our case. Before I move on, as we all know that sarcoidosis, it is a multisystem granulomatous disorder with a bimodal age distribution. Most of the cases presenting within 20 to 50 years of age. This is another a paper from our department only, which compares multiple studies from India as well as Western. All of these studies reach to the conclusion that thoracic involvement forms the major chunk of the patients of sarcoidosis, followed by lymphadenopathy, and third one being the liver involvement. So liver involvement in sarcoidosis. Liver is the third most commonly affected organ after lungs and lymph nodes. An isolated hepatic sarcoidosis, it is considered when hepatic involvement occurs without commonly involved organs like lungs, lymph nodes, or skin. And in itself, isolated hepatic sarcoidosis is a very rare etiology. Till date, there are only 9 case reports on isolated hepatic sarcoid. Most of the patients were between 45 to 65 years of age, and patients had presented with asymptomatic elevation of ALP, to cholestasis, to cirrhosis, to portal hypertension. One patient was even misdiagnosed as hilar cholangiocarcinoma. Other patient as microabscess. Few patients were misdiagnosed as hepatic metastasis also. This is a paper by Graf et al. In which 1,476 patients of sarcoidosis were studied, and only 62 patients had hepatic involvement in sarcoidosis. However, we see that there were only 6 patients who had isolated liver involvement. This was in our case also. Now we have seen that we have studied about FEO. We have looked towards the literature of sarcoidosis presenting as fever of unknown origin. We have also looked towards the case reports of isolated liver involvement. Now we will see, just in case if we get any patient of hepatic sarcoid, what will be the clinical manifestations. Patient will be aged mostly from 20 to 40 years of age, and 50 to 80% of such cases will be asymptomatic. 30% of the patients may have an abnormal liver profile, and 50% of the patients may have organomegaly on radiological examination. Only 15 to 20% of the patients will have a clinically detectable organomegaly. 15% of the patients may complain of abdominal pain. 6 to 8% of the patients with hepatic sarcoid may go on to develop cirrhosis. 3% may go on to develop portal hypertension, and liver failure is very rare. How do we diagnose sarcoidosis? According to American Thoracic Society guidelines 2020, the diagnosis of sarcoidosis relies on three major criteria. First being the compatible clinical presentation, the second being the presence of non-caseating granulomas on HPE, and the third being the exclusion of other granulomatous diseases such as tuberculosis and fungal infection. So once if a patient of whom we suspect hepatic sarcoid comes to us, we carry out the following set of investigations in which we see patient may have anemia, raised ESR, hypercalcemia may be present in 10 to 20% of the patients, and hypercalciuria may be present in 40% of the patients. Hyperbilirubinemia may be there, and there may be increased ALP and GGT in 55 to 73% of the cases. Usually these patients do not have transaminitis. Serum ACE levels and soluble interleukin 2 receptor levels may be increased. What is the soluble interleukin 2 receptor levels? It is a paper by Laura et al. Published in PLOS ONE in 2019, which studied sarcoidosis in 101 patients, and it was found that soluble interleukin 2 receptor levels was more sensitive and a specific marker for sarcoidosis than was ACE levels also. Also, ACE levels may be increased in conditions other than sarcoidosis, example tuberculosis, Hodgkin's disease, primary biliary cirrhosis, which are otherwise also very common differential diagnosis for granulomatous hepatitis. So we see that SLIL2R receptor levels are a major diagnostic, can be considered as a major diagnostic criteria. So once the patient has come with clinical manifestations, we have carried out the laboratory set of investigations, we go for the imaging of the patient. In imaging, hepatomegaly followed by splenomegaly is the most common manifestation, and the patient may have non-contrast enhancing nodules of variable sizes. PET scan may or may not, as in our patient, reveal a hypermetabolic foci in liver. Now coming to the histopathology. It is the most definitive diagnostics for this sarcoidosis. Characteristic morphological criteria features of sarcoidosis are the non-caseating granulomas with asteroid bodies and Schaumann bodies. How do we treat a patient of hepatic sarcoid? Once we have diagnosed based on clinical diagnostic criteria as in ATS 2020, we will proceed to the treatment of the patient. The goal of treatment is to prevent the development of portal hypertension and cirrhosis. So whom do we treat? Treatment for hepatic sarcoidosis is not indicated in patients who are asymptomatic, those who have a normal LFT, or in those who have no evidence of cholestasis. Such patients are only followed with LFT reports and liver elastography. However, if the patient is symptomatic, as in our patient was, deranged LFTs, have cholestasis, or has portal hypertension and cirrhosis, we give steroids to the patient 0.5 mg per kg per day for a period of 6 to 12 months in a tapering dose. In patients who are refractory to steroids or who are intolerant to steroids, we may give alternative agents like methotrexate, azathioprine, etc. Patients who have already developed decompensated cirrhosis, portal hypertension, or in whom there is recurrence of hepatic sarcoidosis even after treatment with steroids are indicated for liver transplant. Take-home message from our cases: isolated hepatic sarcoidosis in itself is a very rare entity. Isolated hepatic sarcoidosis should be considered as a differential of FEO. And in patient with decompensated cirrhosis, after other etiology of cirrhosis has been ruled out, we should work up for sarcoidosis also. In hepatic sarcoidosis, FDG PET may be normal, as was in our case, and patients with hepatic sarcoidosis respond well with steroids. At last, I would like to thank the Department of Radiodiagnosis, Nuclear Medicine, Pathology and Gastroenterology for their worthy contribution. I call upon stage Dr. Ranveer sir for their expert opinions upon the case.
So thank you, Taruna. So this patient presented to us with history of fever, jaundice for about 2 months. So he was evaluated outside adequately, but he remained undiagnosed. So after coming to us with the available history and the examination finding and the available investigation which patient already had, we further evaluated the patient and we found the diagnosis of the isolated hepatic sarcoidosis. So in this case, the fever and jaundice which were presented with the beginning, which obviously suggested that the pathology lies in the liver. Okay. So, but even after further investigations or like the imagings and the other biochemical investigations, we were not able to make the diagnosis till we did the liver biopsy. The reason behind the presentation of this case in today's ACR is that isolated hepatic sarcoidosis is the a rare entity, although it can present with involvement of the other organs. So that is not uncommon thing, but the isolated presentation of the hepatic sarcoidosis is rare. As we have seen, there are only few case reports. And second thing is that if the hepatic sarcoidosis presented with the so much elevated bilirubin, so there is liver involvement should be the significant. So in this significant liver involvement with sarcoidosis, we usually expect there should be some radiological abnormalities. Like particularly in the PET scan, we were expecting that there should be some metabolic uptake should be there, but this was not in this case. So with this comment now, I would like to invite the house for any comments and. Yes, sir, we had done, sir. Ultrasound was also done, sir. Yes, sir. The ultrasound was done outside. Yes, sir. Yes, sir. Sir, we did, but there was no finding. That's why any further imaging. Yes, sir. Any more comments or questions?
Do anything else to rule out an infection before you start steroids? Because infection was one of your differentials.
Yes, sir.
So would you need to do something else to rule out a fungal infection or
Yes,
something?
sir, we had done the serum galactomannan level and the urine antigen for the histoplasmosis as well. So these were negative, sir.
Those would be generally considered enough.
Yes, sir. Sir, these are the important differential for the granulomatous hepatitis. In this case, the tuberculosis is the one important differential. So Montux was the in between indeterminate, and as I already told, histoplasma was negative, and galactomannan was also negative.
Your treatments are diametrically opposite. On the one hand, you have steroids. On the other hand, you would not give steroids.
So that's why we evaluated it thoroughly, sir. So we have the set of list of investigation we have shown, sir.
Sure. So all I wanted to know was that this is generally would be enough to say that there isn't an infection.
Yes, sir.
All imaging and based on the imaging, we did not get anything positive. Like PET was normal, CT was normal, and then we have done because of raised liver function, ALP was raised and bilirubin was also raised. Based on that, we have done the liver biopsy, and liver biopsy was showing there is a non-cageating granulomas. There was no cageation. Generally, in infection, we have necrosis, so there was no necrosis. Based on that, we have started the treatment for sarcoidosis. We ruled out other causes like infection like tuberculosis, which is the most common cause in our setup. And we also ruled out lymphoma also. Thank you.
Thank you.
Any other question? Okay. Thank you very much.